losers take ENT. That kind of a sentiment was being espoused in an ENT journal.
In India, we have a system called we have a guide under whom we are doing the thesis or the research work, which is an important gate pass to our final MS examination. And if these things, if anything, the trainee does which might hamper the guide's repute, then I believe that getting clearance of the guide for the thesis point of view and further for the final MS examination, there might be some bias on the guide's perspective when he or she will be assessing his or her trainee.
Right.
So I feel this is a very harsh but true words. The subject cannot define you. You must define the subject.
Hello viewers, in today's video I'm going to be joined by Dr. Moinak Moitro. Strange role reversal. The last time we spoke, I was the assistant professor and he was working as a government doctor in the West Bengal Health Service. Today, I am working as a government doctor in a health service in some part of the world, and he is the assistant professor working in the West Bengal Medical Education Service. In some ways, he is doing the job that I always wanted to do, and I can't think of anyone more qualified to do the job that he is doing. In my opinion, he is a volcano of talent and perhaps the best ENT doctor India can ever see. So without further ado, let's welcome to the channel once more Dr. Moinak Moitro. Dr. Moinak Moitro, welcome back to my YouTube channel. How are you doing?
Hello, all good. How are you doing?
I'm good. I mentioned in the introduction that in the previous video, I was the assistant professor and you were working in the government health sector as a doctor. And now the roles have been reversed. You are the assistant professor and I am working in the government health sector as a doctor. Only thing is I am working in the UK government sector and not India. How does it feel to become assistant professor? What are the main differences between the two roles that you have recently?
Becoming an assistant professor is a lot of responsibility, I must say, because you are not only treating patients, you are also teaching and trying to incorporate interest of ENT amongst the young upcoming doctors, so that as a teacher you feel good when your students follow your paths. I remember once the person whom I was taught ENT by in my undergraduate days, Dr. Shomo Ghatok sir. He was an RMO at that time at Arjikar Medical College and Hospital where I did my MBBS. So it's a great pleasure for me to be able to work under him as an assistant professor in this department where I am posted right now. And he is also very emotional that I was one of his second batch student and he feels good that he has been successfully able to incorporate interest of ENT in me, that I have taken up this branch for my further advancement in career.
That is so nice to hear. I believe since I have also had 3 years of experience as assistant professor, I think I can safely say that nothing makes a person more proud than to have your student as your colleague. It must be great feeling for Shomo sir. Shomo sir is somebody I also know from my Arjikot days, although I have never worked with him, but we have met multiple times. For the people who don't know, Dr. Moinak Moitro and I, we worked together in Arjikot for a glorious period of 2 years, during which I had adequate exposure to how talented he is, and he has just gone from strength to strength, and today he's one of the best, if not the best. So let us also bring us down to some interesting things that I have noticed in the UK, where I can get your perspective also. If I can ask you, you've been in the world of ENT since 2017, which is a very long time. In these 9 plus years that you've been in the world of ENT, how many times, if you can put a number on it, how many times have you encountered post-tonsillectomy bleed?
Well, frankly speaking, I have been lucky enough that I have not encountered post-tonsillectomy bleeds that often in my institution, wherever I have worked in. But those which I have encountered have really made a mark in my mind. One of the, if I very closely go back to the records, as far as I recall, I have encountered post tonsillectomy bleeds over this duration around 3 times.
So let me underline that.
Really?
Three post
Yes,
tonsillectomy bleeds in nine
yes,
years.
9 years.
Okay. Yeah, please
And
proceed.
that includes my personal private cases and also the institutional cases where I have operated.
And there are enough tonsillectomies happening, so it's not
Yes,
like a normal.
tonsillectomy is a regular surgery and
Yeah.
a routine surgery which is done.
Yes.
But
So three out of
luckily,
three in
when I
nine
had to
years.
encounter when I was on call or on duty, it was 3 to 4. Yeah, I
So
remember three actually.
would you say that okay, even if you have, if even if we double the number,
Yeah,
would you increase? Would you think if you include people who are working with you, their on-call days
yeah.
across this 9 year period, what would an approximate number be?
It would be, I will tell, less than 10.
Less than 10.
Less
Less
than
than
10.
10 in 9 years. Okay.
Yeah.
Do you know that I'm now working in the NHS in the United Kingdom? It has been
Yes, yes.
7 months. Would you like to guess how many post-tonsillectomy bleeds I have seen?
25 maybe.
I
Because I
would
have
say
heard that it is
yes.
quite common. I have heard.
Yes. Oh, you heard that. Okay.
Yeah,
I would see almost one in every week. The target is, I think, close to 10%. So even if you
yeah.
think 10% is the target, that is 10 every for every
Ideally, it
100
should be less
cases.
than 10.
Yeah.
Yeah,
If the target is 10 and if you achieve that, still you're getting 10 cases for every 100 cases. And I would assume that here tonsillectomy is done almost every day in every theater slot. You'll have multiple tonsil cases. So that's a huge number of post tonsillectomy bleed. Now, if you could talk about how post tonsillectomy bleed, how did you deal with them? These, if you want to share
yeah.
your experience.
See, from my experience, two were very, very difficult cases which I had to encounter. Okay. So, first, as we all know, all of the bleeds were secondary hemorrhages, not primary hemorrhages. They were well after 24 hours of surgery. And among, if I give you the statistics of the 3 to 4 cases that I were encountered, one was done in the conventional cold steel manner, and the rest were done by coablation technique, which was done. Okay, so all of the cases had to be taken up in OT because it was not being managed with conservative management.
Mm-hmm.
The antibiotics were stepped up to the next level.
Mm-hmm.
And intraoperatively, out of the 3 cases which we encountered, two were managed just by suturing and ligature, while the remaining one was managed. We had to go for placing surgical and suturing of the anterior and the posterior pillar, such that the bleeding could be controlled.
Right. And what would you attribute in your opinion? You must have some insight on this. What would you attribute this low number of post tonsillectomy bleed in India? What is the one thing that prevents it from happening?
See, there are multifactorial reasons I feel for this. Number one is the if we consider the latest edition of Scott Brown, which have recently come up, if you see that the incidence of secondary hemorrhages is least in cases of cold steel methods. Okay, that's why I think they say old is gold. Every resident and every surgeon must know how to tie a ligature in case of tonsil because that is the very safe way out. Okay. Now, one thing is this that till now, though in the era of coablation, gradually centers are taking up coablation technique, but in the institutions where I have been working for the last few years, they are basically teaching institutions where residents are usually performing the surgeries under strict supervision of the guides. And there, they are first taught, as we know, the cold steel method, where we are just dissecting method and tying the ligature at the lower pole of the tonsil. We all know. This is one of the methods. Statistically speaking, this is favoring the cold steel method compared to the international literature which is available. Another thing I would say is secondary infection, which is the main cause of bleeding. And we all know As far as I know, that in your part of the world, antibiotics are very, very restricted use, and they should be used only when absolutely indicated. But fortunately or unfortunately, that's a matter of debate. It's not like that in India. We are starting off antibiotics right from the time of induction of anesthesia, and they are going for around 7 days in the post-op. Even in the discharge, we give antibiotics. So definitely, considering the uh, antibiotic coverage of the patients in the pre-operative, intraoperative as well as post-operative period, uh, though in the textbooks there is no mention that they are a what I would say a protective factor for tonsillar bleeds. But I feel that can be a contributing factor, though necessary studies need to be done where you are comparing patients who have undergone tonsillectomy with antibiotics and those who are doing without antibiotics. So that I feel is a definitely an important factor where we are providing antibiotics for the patient, which is preventing the occurrence of infection, leading to less incidence of secondary hemorrhage.
I think that is something which can be looked at now that we are in two different parts of the world, and
Yes,
maybe data from my part of the world where I am now and data from your part of the world with the differences
yes,
in our approach and the outcomes. It's a
definitely.
topic of that can be pursued from a research point of view. Yeah. Let us also
Yes,
talk about one more difference that I have noticed. So, just to get you into the conversation, say a patient requires tonsillectomy. Okay, now they have come to you, so they are fulfilling the criteria. The You have the paradise criteria, so they are fulfilling that,
correct.
and then they have come to you, and now you have agreed that the patient requires tonsillectomy. How long do they have to wait before the tonsillectomy is done in your practice?
In my practice, it actually depends on the see when where I used to work earlier. That was an Apex institution. So at that, the case turnover was very fast. They had to wait for around 7 to 8 days. They would have gotten admission because the what I would say we had a huge bulk of patients we used to operate. Each day we had operated around 18 to 20 patients at the previous institution. But when like present situation, when I'm currently working in a limited resource setting where limited number of surgeries are being performed, at this time I would say around 1 to 1.5 months they have to wait to get the date to take admission.
So you work in the place where you think it is more challenging to provide them with a date that they want. They have to wait
Yeah,
for 1 to 1.5 months.
1.5 months. Yes.
Would you say that in India we have a different system than the UK? We have the government set up and we have the private sector as well. What do you
Yeah.
think is the wait time in the private sector when the patient wants tonsillectomy?
I would say that purely depends on the surgeon who is operating in the private sector because I don't think there should be there is the moment the patient is made fit for surgery by the anesthesia team. I think they are taken up for the surgery,
So
providing
basically,
they are following the paradise criteria.
yeah. So yeah, the assumption is that everyone
Yeah,
is
yeah.
is
Everyone is
is
following the
yeah,
paradise
everyone
criteria.
is somebody who is fitting the criteria for tonsillectomy. Once they
Yeah,
are meeting the criteria, you
yeah.
would
But
say that the
definitely in the
max.
recent times,
Yeah.
the incidence of tonsillectomy and adenoidectomy surgeries have drastically gone up in India as well as in West Bengal. Because
Okay.
one is awareness, second is more number of patients are coming up with these obstructive sleep apnea
Yeah.
features, especially the young children,
Yeah.
and they are
Yeah.
taken up for surgery at the earliest.
Yeah. So even you would say that the maximum would be around 1.5 months, not more than that.
Yeah, yeah, yeah.
Do you know do you know how much is the waiting time in the UK?
No, not really. I don't have any
So the
idea.
longest waiting time I have encountered is 10 years. That's that's
Okay,
the, that's the
that's
longest I have seen. The patient was, I think, 3 years old when it was indicated, was 13 years old when the operation happened. Uh, the
any
me
specific reason for this waiting
Well,
time, long waiting
when
time?
I asked that question, the reason I got was the pandemic really messed up the waiting period a lot. So during that time, all elective procedures were put on hold due to various reasons. But main reason that is given is the pandemic. But that doesn't change the fact that even now, when even the target for the tonsillectomy is in months. What
No.
happens, in my opinion, and I think many people will agree with that, is that when you are making somebody wait for that long due to factors that you cannot control, the tonsillitis episodes don't stop. So the person keeps having tonsillitis. We've already met the criteria.
Yes.
You have added them to the waiting list for surgery. You are waiting to operate on them. You are waiting for months. Even if I think about the better cases where we have waited only for months, even then the tonsillitis keeps happening. Tonsillitis turns into peritonsillar abscess. Then, when you are going in for the surgery, that's a much more different field in terms of the operative
Definitely.
field than the tonsillitis which we were accustomed to operating on back home in India. That I feel is also a
Now
factor.
in India, if, I just want to differ. In India, peritonsillitis, the moment the person has a peritonsillitis or a peritonsillar abscess, uh, we do not go straight away for the tonsillectomy. For
Yeah,
that, we first drain the abscess, manage the
yeah,
patient
yeah.
conservatively, let the inflammation subside, and
Yes.
if necessary, then we proceed for tonsillectomy after a few months, I would say.
Yeah, that is the interval tonsillectomy. That is how we do it
Yeah.
in the UK also. I'm saying that
Okay.
the incidence of peritonsillar abscess is comparatively much less because when you are not waiting that long, you're not letting the infection
Yeah.
happen. You can have
Yes.
a de novo peritonsillar abscess also, but that's a different point. But these patients who ultimately undergo surgery in the NHS, many of them have history of peritonsillar abscess. So you know that 2 episodes in adults, 1 episode in children, the way the criteria is met. So sometimes people meet the criteria just because of the quinsy instead of the recurrent episodes of tonsillitis. Also, as you mentioned, coblation, I want to touch upon that as well. When you say coblation, was the incident that you had, was it extracapsular coblation or intracapsular?
It was extracapsular.
Extracapsular. Right.
Extracapsular.
So extracapsular, and I think there is some literature which talks about coblation having slightly higher
Yeah.
post-tonsillectomy bleed, especially in extracapsular.
But the thing is that coagulation is being favored nowadays because it's such a beautiful mode of surgery. Just
Yeah.
because it has a higher incidence of, somewhat higher incidence of post tonsillectomy recurrent secondary hemorrhage. But basically, if it operated correctly, it's a gives a absolutely bloodless field, and the post-op period pain is literally not there.
Hmm. So
Children
it,
are being
yeah,
operated on daycare basis
yes,
at some
yes,
centers.
yes. So in the NHS, all tonsillectomies are day case, irrespective of
Okay.
how you do it. It's always day case. There is a criteria again. It depends upon the distance from home. Some trusts follow it more rigorously than others. So in my previous trust, the rule was that if you are staying more than half an hour away, or yeah, I'm not sure about the figures, but there was a distance and the time criteria. If you were staying beyond that, then you were kept overnight for observation. Otherwise, everyone was sent home. Can I also ask you what is your experience regarding intracapsular tonsillectomy versus extracapsular tonsillectomy?
Uh, I don't have any experience regarding intracapsular tonsillectomy. Now the concept is being coming up with the advent of coagulation about this intracapsular tonsillectomy, also known as tonsillotomy, which
Yeah,
is gradually coming.
tonsillotomy. Yeah, correct.
Especially, yeah, I was reading that in the Scott Brown only that this can be done in children, especially rather than taking out the entire tonsil and go for intracapsular. But from my personal experience, I cannot provide you any information because whatever tonsillectomy I do till date is basically extracapsular
Yeah.
tonsillectomy.
So the logic for intracapsular tonsillotomy is that you just reduce the size. You reduce the size,
Yeah.
especially when the indication is obstructive symptoms. So if you are reducing the size, you are creating enough space. That also causes less pain, earlier recovery, and less. But the chances of bleeding is the same. So coblation, extracapsular, coblation, intracapsular, we never can confidently say which one will bleed, which one will not. We never say that the bleeding chances will be less. The advantage is the pain will be less of intracapsular compared to extracapsular. And we leave it to the patients to decide, patients, parents of the patients to decide which one they prefer. Okay. Do you have any experience of, if you've seen or you know anyone who has done electrocautery tonsillectomy?
Electrocautery, some of my co-faculties have done. I have seen with a bipolar, they
Yeah.
do it.
Yes.
Uh, it was done and okay. But what I felt is that considering the post-operative period of those patients, some pain scores were a little bit higher compared to the
Right.
coablation or the standard cold steel technique that we use. The pain scores were a bit higher in the post-operative period.
And when you are doing cold steel tonsillectomy,
Yeah,
and how long are you keeping the patient in the hospital? When are you discharging?
yeah. In this part of the country where I am practicing of India, we are not doing on daycare basis. At least the centers which I have worked in, at least 3 days we keep the patient admitted. At least 3 days for
And for those
observation.
3 days, they are receiving IV antibiotics.
Yes, for those 3 days they're absolutely receiving IV antibiotics and regularly 2 times they are being followed up for the assessment of the tonsillar fossa, if
Mm-hmm.
any changes is observed or
Right.
not, and if any changes is seen, like there are some, what I would say, there is no bleeding as such, but if there is change in color, the slough is unhealthy,
Mm.
then the antibiotics are taken to the next level of antibiotics from one tier to next.
Okay. All right.
If we have suspicion that there might be an infection which is coming in place,
Based on the
but that's
color
very
of the
very rare.
slough. Based.
Yeah, sometimes the color. Usually, we have a white, healthy-looking slough in the tonsillar tonsil fossa when we are operating with a cold steel method. But sometimes, though rarely, there are some punctate bleeding points which
Mm-hmm.
develop. Though there is no
Yeah.
bleeding, but on examination we find that there are some punctate spots in the tonsillar
Right.
fossa, which I feel can be a marker or
Yeah. Yeah.
for the indicator that this patient is having some infection in the
Mhm.
area.
Yes. Okay. Okay. Let's further explore this topic. Typical cold steel tonsillectomy that you've been doing for a very long time. When you are doing the surgery, is your field highly vascular, lots of bleeding happening when you're doing the surgery?
See, when we are doing uh, cold steel method, there are some. When we learned tonsillectomy, you are also there. You are one of the my first teachers of tonsillectomy, I must say. When we did that,
Okay, thank
uh,
you.
but yeah, the main point in cold steel tonsillectomy always is getting the right plane. The moment there is some bleeding or problem in the there is a bloody field, what I say, that means the plane has not been identified correctly. There might have been, we might have entered into the intratonsillar area which is causing more bleeding. So what we do, what I follow, have learned is that I infiltrate the area with normal saline or with what I would say ropivacaine. That's a local anesthetic as well. We infiltrate the completely along the tonsillar fossa, infiltrate it, and then make the incision at the lateral aspect,
Okay.
and then find the plane. And because of that infiltration, sometimes I feel maybe I might be biased that it is easier to identify the plane. But frankly
Right.
speaking, I have operated on without infiltration also. If the plane is identified correctly, there should not be any problem with related to
No,
the
but do you encounter
plane.
intraoperative bleeding when you're doing the?
Yes, it can be encountered because especially when you are dissecting, you might inadvertently injure the peritonsillar vein, and there you might have a bleed. But most cases, the peritonsillar vein is encountered towards the lower pole. One might encounter that is already you will come across, but we will ligate it at the end.
Yes.
But if at all, it is not a regular finding, I would say. If the plane is identified, we just go for a blunt dissection with a cotton ball. We make the
Right.
cotton ball, hold the tonsil with the hand, retract it medially, and just rub it across the,
Right.
what I would say, the tonsillar bed to dissect it off the tonsillar bed.
So would you say the cotton ball is absorbing the blood as well as dissecting whatever little bleeding is happening? to be able to see the
See, if
plane?
the cotton ball was absorbing, it is definitely absorbing some amount of blood, little bit
Mm-hmm.
of blood, definitely. But if there is too much bleeding, then we have to suction the cotton ball as well. But
Mm-hmm.
usually that is not needed regularly.
So you are saying that the tonsillectomy you are doing with cold steel, you are seeing maybe few milliliters of bleeding while you are doing the surgery.
Not few milliliters, it is definitely more than what we encounter with cases of coagulation. Coagulation is literally bloodless.
Mm-hmm.
For, considering a standard cotton ball size which we encounter, if it is done by a senior surgeon, for each side maximum 2 to 3 cotton balls will be used,
Right.
considering that each cotton ball is soaked up with blood and then they are replaced with a fresh cotton ball.
Mm-hmm.
So 2 to 3 cotton balls. So how much bleed can we might calculate regarding that. So one cotton ball, how much that needs to be assessed to get
Okay.
a
So you would maybe
idea
say
regarding the
100,
bleed.
100 ml maximum. Yeah. Less than that?
Maximum, I don't think it is
Yeah.
100 ml, not even 100 ml.
50 ml.
100 ml is also, yeah, 50 max.
All right. Is it a standard practice even now in India or in the tonsillectomy that you are doing to have a pharyngeal pack?
Yes, always we place a pharyngeal pack, be it cold steel, be it coablation. Because I have seen one case where the surgeon was operating with a coablation and there was an anomalous vessel which was coming up from the lower pole itself, and there was bleed. There was sudden spurt of bleed, and we ultimately had to ligate that vessel as well because the coagulation was not coagulating, and it was a high flow vessel basically.
Right.
So we had to commit to that, and because you never know when to expect, but it is better to be safe and just pack the entire area, and then we can
So
proceed
what
to the
happened?
surgery.
What happened in that patient with the high flow vessel?
Yeah, with the hypoband, we were able to control it with the artery forceps and then ligated it.
Right.
We attempted 2 to 3 times of coagulation, but because it was a high flow, it was not of much use. So we just went for, rather than waiting and trying more,
Right.
2 attempts maximum. Because it did not stop, we went for the
And in that
traditional
case,
ligature.
the pharyngeal pack was there even though you were doing
Yes,
coblation.
yes, yes, yes,
So
yes, yes,
so that's the you're arguing in favor of having a pharyngeal pack even in potentially
yes,
bloodless surgeries because anything can happen. Yeah.
yes, 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 definitely.
So what does the pharyngeal pack do? What is the role of the pharyngeal pack?
See, basically, we have uh, the airway is already secured. The
Yeah.
moment we have uh, this cuff in the
Yeah.
airway, the
Endotracheal
airway is
tube cuff.
already
Yeah.
secured, endotracheal tube is already secured. But see, blood is a very bad irritant to the airway. So it is better if we do not give a pharyngeal pack, that blood might enter and get collected over the balloon. We will suction that and get removed, but this blood, whatever it is a very irritant thing to the sophisticated airways. So there is no point, I feel, in taking a risk rather than we pack the entire opening of the airway with the pharyngeal pack, and the balloon is already there as a second line of protection. So I feel that
So two
I
lines.
am very comfortable with the
Two
pharyngeal
lines of
pack.
protection and prevention of irritation to the airway.
Yes.
So, do you know why I'm asking these questions?
Why? Because I feel in your part of the world, you are not using pharyngeal packs
Got it.
regularly.
That is the first question I had asked when I came here. When I saw my first
Yeah.
tonsillectomy, I asked, "Is there a pharyngeal pack?" And the reply I got from the anesthesia doctor is, "We don't do it. We don't do that here." I don't know why they don't do it here. I should be
Yeah.
finding out. Probably there is a possibility. So in the NHS, we have these things known as never events. Never event is something which should never happen. So probably there is a possibility of a pharyngeal pack being left behind or
Left
pharyngeal
behind.
pack
Yes. That can be a
inadvertently going
possibility.
too far in and then not being able to recover it. Maybe
Okay.
that is I don't know. Again, this is speculation, but I should ask and find out. But pharyngeal
Yeah.
pack is never used. So I had asked them that what about all this?
Yeah, that is definitely a when we are using a pharyngeal pack, that should be removed during extubation of the patient before after the surgery is complete. So what I try to follow and tell my anesthetist is that keep the pack long, keep an end of the pack coming out to the mouth. So whatever it is, you will find that something is sticking out the mouth, and you will remove it at the end of the procedure.
Yes.
But
Yeah.
yes, there have been instances I have heard where the pharyngeal pack was packed so tightly that it had gone into the esophagus, and somehow it was recovered from the esophagus because when residents are operating, when we tell them pack it properly, they pushed so much that it has gone. Some part of the pack has gone into the esophagus, and they have done a brilliant surgery. And after that, the pack is not being found, the
Hmm.
entire thing. Then it was taken out. It happened in a reputed institution, but no harm was caused, and the pack was uneventfully recovered.
I think that is the thing about the NHS is they try to design systems here. They try to design systems in a way that even people who are doing it for the first time, because tonsillectomy is a surgery that is done by people for the first time. The first ENT surgery is usually tonsillectomy on many occasions. So the systems are designed in a way that the maximum safety is ensured in all places. So this neatly helps me transition into the next part of the discussion. What I have seen in the NHS is surgical trainees. Both of us have been surgical trainees in the past. An argument can be made that I am again a surgical trainee, but uh, we have seen surgical trainees. We've been surgical trainees. We were aspiring to be surgical trainees. When we became surgical trainees, then we trained surgical trainees. So we've had enough experience, I believe. What I have seen in the NHS is that across the board, across all trusts, there is a uniform system in terms of how surgical trainees, especially in ENT, I'm sure in other subjects also, but I can only talk about ENT. In ENT, there is a uniform guideline regarding these are the things you need to do in this time, in this number, and in this way. So, what I'm trying to say is the quality of training that trainees receive across the entire United Kingdom is more or less uniform. I'm sure there are individual variations. I'm sure a person trained in Cambridge, for example, would be probably different from a person trained in a different part of the UK, maybe. But the goal always is to have the same criteria and everyone should be meeting them. If a particular hospital gets trainees and they are not able to provide the same opportunities, same support to the trainee that is expected, if that does not happen, do you know what happens to that situation? What happens in that situation? So, for example, in
No.
India, if I have seen trainees who have not got much opportunities, and I've also been a trainee who was lucky to have opportunities, and I've heard of others who have been comparing that so and so thing. This happens in my hospital. Does this happen in your hospital? And when it doesn't happen, then the other trainee
Yeah.
feels bad. Okay,
Yeah.
and I mean we've been there. I have felt that as well. I'm sure you have
Yes.
also.
Yes. Yes.
So, but in
Yes.
the
Yes.
UK, if a minimum there is a minimum criteria. I'm sure you can go beyond that. But if you are not getting that, the trainee is reallocated to a different hospital. They take the trainees away
That's
from the
good.
hospital.
That's really good.
They
Yeah.
they they tell the hospital you are not effectively. They tell the hospital that you are not providing the kind of support the trainee needs. So here you have deaneries. So different parts of the UK have deaneries, like we have the National Medical Commission and state medical commissions and universities. So the trainees are affiliated under deaneries. I think the term has changed to something else now, local education board or something. But effectively, they are under deaneries and they rotate across different hospitals. And if and they keep providing feedback to the deanery they are affiliated with. If it does not meet the criteria, and this has happened, I have heard of it from my colleagues, they just stop sending others, and even the ones who are already there, they are sent to other places. Which brings me to a question. What do you think about this vast difference that exists across India is a very big country and every state has its own challenges. What do you think about this vast difference in the quality of training that different trainees receive, especially surgical trainees? What is your opinion?
See, I would say there are a number of factors and which are being followed across the country. Is the first is a lack of uniformity, as you mentioned. We all know uh, now NMC is gradually coming up with I would say unified protocols regarding how a surgical trainee and not only trainees, how teachers should also be performing, and student feedback is of utmost importance about how the teacher is teaching as well. So their teachers are also being subjected to various courses like the BCME and stuff like that. But the problem is that what we are mm, making up or protocolizing on paper is not being implemented equally across the country.
Yeah.
So why is it not being implemented? That is not, I won't be able to comment because that's not my job, and also it is beyond my scope as well. But I feel with as the days are passing, I feel NMC is doing a good job, that they are trying to bring every medical college and every training center of the residents how will they will be taught. They are opening up skill labs, which before allowing the residents to take up surgery on a patient, they'll be doing the surgery on mannequins and things like that, which I believe we did not have access to at that
No.
at our times.
No.
Yes, and rest. I think, see, the good thing about the what you said at your at UK, that residents have the advantage and they can go back and tell the
Exactly.
authorities that they are not being provided with equal cases. It is
Exactly.
not in this part of the world, and there are a number of factors which the residents fear.
Can we
Yes,
talk about that?
because
So imagine there's a fictitious
yes,
resident because no such resident
yeah,
exists in India. But let's create a fictitious resident who is
yeah.
unhappy with the number of cases he's getting exposed to. He's feeling that he's not learning enough surgeries, he's not getting enough exposure. Now he decides to talk to or write an email to the university he is in affiliated with. What do you think will happen to that person? What is the best thing that can happen to that person?
If I was the head of the university, I would have been able to tell it better. They listen to the person whom has complained, what he or she has to tell, and because in our part of the country, we should always know that there are two sides of the same coin. What someone is telling might not be true. It might be
Right?
true according to him,
Yeah, perfect.
and
True.
I think it can be sought, but by face-to-face meeting of the department or the unit in charge under whom he or she is working, and
Does
some
this
neutral
happen?
person
Do you
might be
think this
there.
happens?
No,
Do
no, I have
people?
never seen.
You've
I
never
have
seen.
never seen or never heard of.
Why do you think it never
Neither I
happens?
have heard of. Why do I think it never happens? Because in India, we have a system called, we have a guide under whom we are doing the thesis or the research work, which is an important gate pass to our final MS examination. And if these things, if anything, the trainee does which might hamper the guide's repute, then I believe that getting clearance of the guide for the thesis point of view and further for the final MS examination, there might be some bias on the guide's perspective when he or she will be assessing his or her training.
Right.
So
So
I
there,
feel this is a very harsh but true words which I have said.
there is a lot of
And there are
fear.
also, yes, definitely it's a part of a fear. But see, in the recent era, I have seen young students. Being a teacher, I am encountering young interns as well. Fear these days is much less,
Which is a good thing or a bad thing?
which is a good thing in most cases. But some instances, I feel fear should be there, because the moment you have fear, you will work regularly and with full focus.
Yeah. And
Casual,
it also makes a doctor more safe.
yes, the primary motive, it's basically a balance which should be maintained. I'm not telling that you just go and thrash your residents and demotivate him or her that you are worthless, useless, you are not doing anything, don't give him cases, not like that. Neither you boast your residents so much that, oh, you are the best, you are the best, you are God gifted hands, not like that. There
Mm-hmm.
should be a balance. We all have encountered our
Yeah.
seniors, we all have gone through this grind.
Mm-hmm.
I'm not telling that we should do what our seniors have done. Not like that, but there should be a balance between
Yeah.
scolding as well as what I would say, uh, telling your residents that they have done a quite a good job.
Yeah. Do you think, and I'm putting you on the spot here because you are actually an assistant professor, something I used to be. I may be again in the future, who knows? Nobody knows what the future brings. But now that you are the assistant professor, let me ask you one thing. Do you think in India there is a lack of proper training methods for teachers? Like how to be a
Yes,
kind of teacher you should be? Do you think in India is more of an
yes.
informal method that we tend to teach the way we liked to have been taught? Or sometimes we just teach in the way that everyone we knew taught?
Yeah, definitely. There is no standard guidelines. It is gradually coming up by the NMC regarding how a teacher should be teaching his or her students, because from my knowledge from my experience as a student of medical science, I know you have the same experience as well. We have encountered two extreme spectrum of teachers. I'm not
Right.
telling anyone who is bad or good or whatever. We have encountered some teachers who came to the class, read out a PowerPoint presentation in black and white, word by word, everything, 30 to 40 slides in 1 hour, just running reading. We have encountered these teachers, and we have also encountered teachers who are not using any presentation, who are not using chalk and duster, but just by the way he or she is teaching is what I would say, is forcing the students to listen and gain interest in the topic which is being taught. So I'm sure you would be agreeing with me regarding this. So,
Yep.
but these two extremes are very distant from each other. There should be something in between which should be standardized.
Yeah.
Everything in modern medicine should be standardized as per
Exactly.
protocols. So NMC is now coming up with these things. And as a teacher, I am also learning what they are trying to say and
Yep.
how to incorporate the training which I am getting to teach my juniors. I
Yes.
might not be comfortable regarding some things, but still I have to adapt because
Yeah.
standardization is of utmost importance during teaching as well.
Yes. So back when I was an assistant professor, I remember doing a workshop on basic course in the use of medical education technology.
Yeah,
Yeah.
BCME.
Yeah. So that was an eye-opening experience for me. Then we have the basic course in biomedical research. All of these are mandatory criteria. We have seen changes happening in our own lifetimes. So I don't know about you. Maybe you are younger, too young for me to be able to relate to in this way. But back when I was preparing for MBBS entrance exam, we had many exams. It was not a single exam. Were you? It was the
Yeah.
same for you? Yeah.
Yeah, same for me. Yeah.
Yeah. Okay. So we are in the same
We had a
category.
All
Yeah.
India CBSE
Yes.
PMT exam, and the
Yes.
institution, central institutes had separate exams like
Yes.
PGI and
So AIMS had
stuff
a,
like that. AIMS,
PGI is
AIMS had
postponed,
a
right?
separate exam.
PG,
Yeah, sorry,
let
AIMS had a separate
yes.
exam,
BHU
and we
had
had a
separate
state exam
exam.
as well,
Yeah.
and a state exam as
Yes,
well.
state exam as well. So each
Yeah,
state had their own exam. Elite institutes had their own exam, and all India there was the CBSE pre-medical test. So we went in the standardization route. Perhaps that was one of the arguments. Some people I know don't like it, but the argument was have a single exam, uniform evaluation, neat UG, and we know what the controversies are. So let's
yeah,
let's
yeah, yeah.
let's sidestep the controversies for now. But at least the vision was towards the uniform way. That's where we wanted to go with a single exam for undergraduate entrance, single exam for postgraduate entrance, single exam for super specialization. So everything moved towards single exam with the goal of a uniformity, standardization. I think those were the goals. Do you think a similar
Yeah, yeah.
standardized protocol can be devised for surgical trainers also? So for those in surgical specialties who are now in positions of faculty such as yourself, can there be training provided regarding how to train a surgical trainee across India?
Yes, definitely. See, medical science is always improving with days going by. So, uh, the thing which is of utmost importance is that everything should be evidence based. I have encountered people who have talked that uh, this is my experience. I don't
Yeah.
go by books. I don't go by figures and stuff like that. But frankly speaking, that is the least level of evidence.
Yeah.
So the moment uh,
Level 5.
surgeons will be teaching, the faculties will be teaching the students, be it practical or theoretical knowledge, which is evidence based regarding what is to be done, how it is to be done, and when it is to be not done.
Uh-huh.
So all these factors should be incorporated in every faculty, either through training or through continuing medical education regarding, and workshops might be also taken up regarding how to teach.
Yeah.
Because frankly speaking, I have also seen teachers. It might sound a bit harsh that they do not know to inculcate the uh, importance as well as interest of a particular topic or subject which he or she is teaching to the
Mhm.
students. Now, the moment this happens, the student won't pay attention, and that knowledge will there'll be a gap in the knowledge. And
Mhm.
in medical science, gap in knowledge can have dire consequences.
Right. Let's stay on this slightly controversial topic. Um, I read a post. Are you familiar with Dr. Sumer Sethi?
Yeah.
Yes. So I read a post by Dr. Sumer Sethi, and he's not the only one. I should not be singling him out, but this is a. I've seen number of posts like this on social media, which talks about so X number of new MBBS seats have been approved this year. The number is always huge, and the argument is that now we are having a lot of students getting the opportunity to become doctors by completing MBBS. And what they say is that while this is good, definitely you should allow more opportunities for people to become doctors, but the quality of education that they are getting, the quality of training they are getting, is often not of the standard that people are comfortable with, that doctors should receive in any country, not just India. They should receive high quality education, high quality training. That quality is not being assured because of two reasons. Number one, every medical college does not have enough patients so that they don't get enough clinical exposure to learn, which is, I think, the main difference between the government colleges and the private colleges that we have. Although there are exceptions to every rule, so you will have a government college with less patients and a private college with more patients also. But lack of patient, by as a thumb rule, you can say government colleges have more clinical exposure because there are more patients. And number of faculties. To which I will also add,
Yes.
there is also something I have seen, not just in the teachers, but my contemporaries, some of whom were not interested in becoming teachers. So there is a general lack of interest in teaching. People think that I'm doing so much work, clinical work, which is true. They are. I mean, I've seen doctors. I've been a doctor in India. There is a lot of clinical work. To add to that educational responsibilities, it becomes difficult. So I would say there are three reasons why medical students are not getting the uniform level of high quality training that they receive. That is lack of patients, lack of faculties. Many places you have vacancies which are not filled, and even those vacancies which are filled by people who, as you mentioned, they don't have a standardized training, which is not their fault. But there are those teachers as well who are not motivated enough to provide teaching in a way that a medical student deserves. How do you think you solve the situation, in your opinion?
See, the first thing which should be done is ensuring strict guidelines to be followed in setting up of a medical college. The recently the organization, as we know, the NMC, who is providing license to medical colleges across the India, the guidelines, the standards are, I feel, are gradually day by day it's becoming easier and easier. The benchmarks have been coming down to much lower levels than what was the requirement for opening up a medical institution, especially a medical college, say 10 years back. It had a lot of criteria, which was important. I'm not saying that is bad, but easier regulations for opening up a medical college will definitely means at some place things will get hampered. Be it faculty, be it patient load, be it students who are coming up, be it the facilities which the students are facing as well as the patients are getting. So I feel the actions should start from that level, that the bare minimum standard of a functional, well equipped medical college should be established, and each and every medical college across the country should be following these basic standards. And if anyone fails, the recognition should be removed from that. But it is easier said than done in India, we all know, for various reasons, which we should not be talking about here. Uh, but yes, uh, standardization, again coming back to the same thing, basically the moment teaching is something which is, some people are doing it by force, some people are doing it by passion. So what can be done is that we should find candidates who are passionate regarding their teaching, and those who are passionate will definitely try to incorporate whatever they know into the students with whom he or she is teaching. I'm not saying anyone is low like that, but still I feel that there must be some difference between a passion and a profession. If I am enjoying what I am doing, then only I'll be able to teach my students also what actually is happening. And especially in ENT, I would like to take up the point is, I don't know about UK, but in India, ENT is still a subject which is lagging behind, considering the interest of students in the postgraduate residency. It has definitely improved somewhat than when we were taking up the subject. But one thing I feel,
Can I interrupt you there?
I
I want to
yes,
mention one thing.
yes, yes,
I
yes.
used to think exactly like that. You, there was a moment in my life where I started to doubt this thinking. Do you know when that moment was?
When?
It was in 2017, early May, when you joined in ENT.
Oh God, how am I responsible for this?
When you joined ENT, before that point, I used to think, and in fact, I'll let you finish your point, but I want to say something. In one of if I'm not wrong, this is the National Journal of ENT in India. They had an article published, and maybe again getting the
Yes,
journal's name wrong, but they have an article published that top 2000 rankers don't take ENT.
yes,
That was
yes.
an
It was,
article.
I think, 2 years back. 2 years back, this article was taken up.
And I was very scandalized by that, that you are publishing in the ENT journal that top 2000 rankers are not taking ENT. You are not giving any solutions. You're basically highlighting the fact that ENT is not an
Yeah.
attractive subject. And the answers were not thought about in the journal. There were no solutions provided
Yes.
to the problem, if I remember.
It
So
was just an
basically,
kind of
yeah,
an observational
just an
survey which they
observation.
had published.
Yeah. So in
Yeah.
my mind, in very layman's terms, it was like losers take ENT. That kind of a sentiment was being espoused in an ENT journal. I found that amazing. But anyway, when I took ENT, it was not my first choice, and in my first few months, I was not surrounded by anyone who I felt has taken ENT by choice. There was one person, of course. There's an exception to that as well, but mostly people were openly admitting that okay, I didn't get this. That is why I'm doing ENT. But when you joined ENT, for the first few weeks, if you remember, I didn't take you seriously because I was 100% sure you're going to go for a different branch. So why waste time talking to you? You're going to leave anyway. Then, after a few months, when I realized that the window has closed for you to change this year, maybe next year you might change. But then I realized this guy who is so smart, who has been a top student throughout his MBBS every single year, if he can consider this subject to be worthy, then maybe the psychology of medical students regarding the worth of ENT as a subject worth specializing in is changing. So you can continue now.
Yeah. So the thing is that I have talked with a lot of people. Why they consider ENT as a so-called minor subject, because we are dealing. Coming back to my old saying that we ENT surgeons are dealing from the dura to the pleura. If we remember, we had a
Yep.
talk.
Yep.
So what I found, and the answer was from a number of students, which is when we are self-introspecting as ENT teachers, we should be important to that, is that, sir, we don't get to see what is happening when you guys are operating.
Yeah.
Yes, that's a very important
Yeah.
thing.
Yeah.
But with the modern era of endoscopes and camera systems and beam splitters for microscope, where you are projecting that entire thing on the
Yes.
big monitor, I try to teach my students like that. When I'm operating, they are there in the OT, they are seeing the big screen. See, this is how a tympanic membrane looks like, how a perforation looks like. I'm not going into the detailed surgical steps, they do not require at that level. For the undergraduates, I mean. This is how a malleus looks, how an incudomalleal joint looks, incudostapedial joint looks.
Yeah.
So, the moment I started teaching like this, they are very, very interested. They start developing the interest. So what I feel that we ENT surgeons at one point of time were very conservative. Majority of people, though they were taking up ENT as a branch, preferred to go for the conservative management just by ear drops and eye drops and kind
Yeah.
of going on and
Yeah.
on
Yeah.
with the field. But with days passing by, with advent of newer technology, newer skills amongst the new generation of ENT surgeons, if I may convey, which includes a number of our seniors also. ENT is now gradually be considered as definitely a purely surgical branch. I know there are some other aspects,
Yes.
but what I tell my juniors who are now undergraduates or who have taken up ENT as a postgraduate subject is that you will not get bored in the subject. It has so much of variety, so many different kinds of surgeries. You might not be good in all of them, but you can be excellent in some of them also. So you can take your branch. Like some, I've encountered people who do not find interest in otology. I find extreme interest in otology, but they are more
Yeah.
they are more interested in head neck surgery. So that
Yeah.
is also a part of ENT,
Yeah.
definitely.
Yeah.
And with this, in the recent past, we all know that ENT has also opened up as a branch where you can pursue for MCH neurosurgery, MCH head and neck surgery, MCH plastic surgery, and
Surgical
so
oncology.
basically, yeah, surgical oncology, yes. So that is also, I feel, an important factor regarding that. And definitely, I must say that I took up ENT. Definitely, it was one of my favorite subjects from undergraduate days. I was lucky to be taught by some exceptional teachers. We all know Mukesh sir as well. We encountered Mukesh sir in our
Yeah.
residency as well. He was there in my undergraduate day also. So that's the thing. The way you are taught in your what I would say in your childhood level of medical science when you are dealing, you will obviously, depending on how you are taught, you will gain interest or not. Most importantly, and another thing I must say that after few years back, when I have done my residency, I was just seeing a speech by Dr. Janakiram. We all know that.
Yeah. Yeah.
We all know him. He's a brilliant
N
surgeon with
Jankiram.
uh-huh.
N Jankiram. Because his son is also
N.
Jankiram.
Janakiram,
Yeah.
Narayana Janakiram. Yeah.
Yeah.
So, Mr. Janakiram, Dr. Janakiram had said one thing that he was also talking regarding this only. Why people are not taking up ENT? Why they are feeling they should not take up ENT? It is not that a good branch or whatever like that. So he was telling the audience, one should remember that the subject cannot define you. You must define the subject. So those are the words I feel that is very important. Whatever subject, any subject you are taking up, be it clinical, paraclinical, surgical, non-surgical, whatever it is that person concerned whether he or she has that spark to take that subject to the next level or not. And it is purely what I would say individual specific. That not all of us have that spark. Not all of us have that what I would say gifted hands, gifted minds, gifted brains, whatever it is. I use the term gifted because somewhere or the other you might work hard, whatever it is. Luck and God's grace is very important for moving forward in your life. So that is very important. So that is what I need to say, that as a teacher I am trying to incorporate with my full uh, what I would say interest, that to develop students who will definitely take up ENT in their future.
I understand, but do you think there are system level changes that can happen which can attract or ensure patients, attract and ensure motivated faculties in medical colleges so that the MBBS students can get what they deserve? Is there any system level change you can think of? You mentioned that
See,
the
doctors
criteria
have
for
always been very,
You mentioned the criteria for medical colleges should be strictly enforced and met. I understand that. But say a
yeah.
college has, so I'll tell you a story from my life. So I did MBBS from Institute of Postgraduate Medical Education Research, a place that you are familiar with. Okay. So
Yeah.
this place, when I studied there, the first year of my MBBS, that college was not recognized. It was still awaiting recognition because they started in 2004 and you need five batches to be there. The intern batch has to be there. Only then you get the final recognition. So when I reached second year, that is when they received full recognition. For that 1 year, I was worried that I am in a medical college that is not going to be recognized, and I'll have to go through the entire process again of West Bengal joint entrance and MBBS entrance exams. Now I fully agree with you that if a college does not meet the criteria for being recognized, it should be stripped of its recognition. It should no longer be allowed to function as a medical college. I fully agree with that. What happens to the medical college students who are already in that college? What do you think should happen to them?
No, no, definitely. I'm not, that's a matter of great issue. Even we encountered in our state only few years back when a medical college was stripped of its recognition due to various reasons,
Yeah.
and the students were suffering miserably. So I'm telling that that is up to the policymakers how they will handle. I'm not qualified enough to tell that.
I have a
But
suggestion. I have a suggestion.
yeah,
Just like
yeah,
I have seen in the UK, and I guess whenever in India the problem is, I'm sure it's not an India specific problem, but we have a problem for every solution. So the moment I will give a solution, there will be ten possible explanations why it will not work in India, which is true. I'm not saying I have all the solutions. But what I have seen here is if a student or a trainee is not able to get what they deserve, then they are reallocated to a different place. Now you have 100, 200, whatever the number is. You reallocate them to the
yeah,
places which are already functioning. That I think is a simple solution. And so the places,
yeah.
the medical
You can
college should have
distribute the students
ongoing,
among the recognized institutions.
they should have an
But I
ongoing
don't know.
evaluation where they
Yeah,
need to
just one
continuously
thing I need to
improve.
ask you regarding the UK.
Yeah.
The persons who are taking up the undergraduate course, I mean, is it based on some ranking system that
Oh, that is such a
that's
nice
a
question. I am so happy you
yes
asked that question.
regarding
So,
which
yeah,
institution they take up?
yeah, yeah. That's such a nice question. So, so we are now talking about, we are talking to each other in the aftermath of the NEET UG paper leak happening and a lot of controversy regarding that. The most recent time that happened was 2 years back. And I had already started this channel back then, and there was a lot of, I would say, I found it very difficult to not talk about it then, as difficult as I find it to not talk about it now. What I ended up doing is, instead of focusing on the problems that are so well documented in India, I wanted to see how things are done in other countries. So there are two videos, I think,
Yeah.
or three videos on my channel where I compared how people become doctors in India versus in the UK versus the United States of America. So in the UK, the system is, it's not based on any exam. That's the most important thing. There is no NEET UG equivalent in UK. That just doesn't exist. US does have. I think the exam is called MCAT, medical something admission, medical college admission test. But in the UK, there is no such exam. So UK, the criteria is based on the, so for our Indian view, is like your 10th and 12th subject marks. So here I think it's called A level or something like that. So just your school marks that defines whether you are eligible or not. You have to get really good score. And then there is an interview. In that
Okay.
interview, so you have to become eligible for the interview. But in that interview, this is something I had highlighted in the video. In that interview, they don't just assess your intelligence or your suitability for doctors from an intellectual point of view. They also assess whether emotionally, socially, you have the empathy, you have the genuine interest. You touched upon the point passion. So they have to
Yeah.
demonstrate in the interview that they have done something in their lives. Leading up to that interview, they have done something. They've either volunteered or they have worked with some organization. Different ways in which you can demonstrate that. And there are dedicated channels which talk about on YouTube, which talk about how to become a doctor in the UK, done by UK doctors. So you have to demonstrate all that. Essentially, you have to demonstrate the character, not just the intelligence, the character that you will make a good doctor, which is so important. And which aspect of the exams in India assesses that? Whether it is during entrance exams or it is during the university exams, the exit exams, nothing. We do have 8Com now, but it's largely
Yeah.
related to a minor component of it. That okay, that's also there.
Yeah.
We will test you on this also. It's not taken as seriously as it should be, because when we interact with patients obviously want to be treated in the right way in terms of accurate treatment,
Definitely.
but they also want to be treated in the right way in the way that you communicate with them. They are not interested in meeting the most, I mean, of course, many people are, there's no absolute, but they are not interested in meeting an excellent doctor who is very rude and even not interested in answering questions in the proper way. So yeah, in the UK, the system across the board is not based on exams. In fact, the rank system doesn't exist, which has its own problems again. I'm not saying the system here is perfect. Because the rank system doesn't exist, you have this weird situation where you have highly qualified people still waiting for a job. So they have passed all the exams, they are qualified, they are eligible to be doctors, or they are still doctors, but they're eligible to receive higher training, but they're just sitting there because the number of training slots are fixed. So if more than so and if you just decided on a basis of an interview,
Yeah.
and they have done everything that is possible to be done. But again, here in the UK, again, this is amazing. In India, we had publication requirements, but that was based on certain indices. So you had to have a publication which is listed in the journal, which is part of a certain index. That is all that was there.
Yeah.
Here, the quality of the research is also assessed. So it's not enough to have publications. They have understood that people can publish anything, and journals are also trying to fill their pages. Even good journals,
Yeah.
which have high APC, still they are trying to. They need to keep coming up with issues. So they've figured that part out as well. And now they are ranking people on the basis of, or not ranking, giving scores on the basis of the quality of research. And then I ask the question: how do you decide which quality is higher? What is the criteria there? And you will not believe, in India, when you want, so say you today, you are assistant professor, tomorrow you decide you want to do MCH in plastic surgery. You have suddenly woken up to the reality that plastic surgery is great, and tomorrow you want to appear in plastic surgery and need assess for plastic surgery. What will be the process? You will apply for it.
Give a neat
Yeah.
assess. Yeah.
Yeah. So there is the website, you will apply for it. Do you need any certification from a plastic surgeon that you can go into plastic surgery?
Here, there you need it, I feel.
You don't need it exactly. So in the UK, if I want to do something in ENT, something further, not even in different subject, something in ENT, there should be three people who are at the top of their game.
Recommending you.
Yeah, three people at the top of the game. So they are the highest designation in ENT. They should sign, they should put their name on paper or digital, whatever it is, but they have to put their name on a verifiable document saying that, yes, I am saying that this person has enough knowledge to not perform badly in the exam.
Okay.
And think about it, if on the day of the exam I have a bad day and I answer very poorly, so it's possible for anyone.
Yeah.
Yeah. If
Any of us
I
can suffer
answer
like.
if I answer so poorly that they think that I should not have been even appearing in the exam, who gets penalized? What do you think? Who gets penalized?
The person who is recommending.
The person who has recommended. So it has created a system where you don't get these permissions to appear in exams seriously. I mean, the system is
So
so
how do
serious.
you create rapport with the person so that he or she is recommending you? You work under
Again,
him.
it's not just about rapport. So this is the thing I was trying to highlight in the discussion we had a while back, that in India, if there is a resident who is unhappy with their training, they generally don't complain because they are afraid of spoiling their equation with their seniors, because they still have to continue working in the same department after they have complained. So today you complain, tomorrow you go to the same department. So then who is your friend in the department now? How do you survive? So, and that's also because while there is always a possibility that some action will be taken against the senior, chances are less, and it's a one off, it's not something which is always possible. Here, if so, first of all, it's a two-way thing. Both people are held accountable. I go to a senior and I say, can you sign me off? He tells me that, see, if I sign you off and you don't prove to be good enough, then I get into trouble. So then I also understand that it is not something which is an individual lack of good relationship which is leading him to come to that conclusion. He needs to be protective of his own self-interest also. I think self-interest is
Yeah.
the most important thing. It's We as doctors, we are trying to treat patients properly because we know if we don't treat patients properly, something bad can happen to us also. So that
Yes.
it should motivate you in a proper way. So, but on the contrary, if nobody agrees to sign you off, saying that I don't want to ever take the risk, then they run the risk of the trainee complaining. Yeah. So the trainee can complain. So it balances both people. So there is a central agency, whether it's the deanery or the General Medical Council, they are monitoring everyone at every stage. So you don't reach a stage. In India, you do. Although even in India, you have the state agencies, the medical councils, where we are always answerable at every stage of our lives. But it's not an ongoing process that every day, every year, at some point, somebody will come to us and we have to do something and that will be evaluated. It's not ongoing. A bad incident can happen and then we can be under the scrutiny. That is known to happen to many people. But this is how it is. So, in India, if a student doesn't do well, the teacher has nothing to say about it. So you didn't
Yeah.
study. I remember the first
Couldn't.
class I attended, and this is one of my favorite teachers who said this, that whether you pass or fail, my salary won't change. So my salary doesn't depend on the quality of your performance. And I don't want it to depend also, but there should be some system in place, some process of engagement where there is an independent arbiter who is approachable by both sides, as you mentioned,
Yeah.
and it should be a continuous
Yes,
process.
that is true. That there should be accountability from the teacher's perspective as well. Definitely.
Yeah. So yeah, yeah.
A teacher, we all know we have encountered teachers who have not taught us, but before the exam they are like behaving like anything that you did not study.
Yeah.
Teachers should also be held accountable, that they should be also be teaching to the students who are placed under them, or the residents who are
Yes.
placed under.
So I feel that this, whenever we undergo this process of getting hired. So either it is, we go through this process, which is either we are appearing in an exam to get into a course to study, or we are going through some sort of an exam or an interview process to get hired as a professional in some places. I think that again, I'm saying it, but I don't know how much it will be implemented or it will ever be even considered. The certain evaluation of the character of the person you are hiring as a professional, regarding how motivated they are to teach, or how
Yeah.
motivated a student is to pursue, because it requires so much sustained effort for such a long period of time, from
Yeah.
getting that rank in your MBBS entrance exam to then becoming a professional that you want to be. It's such a long process. To be able to stay the course requires a lot of mental effort. So do you have that
Yes.
tenacity? So there can be psychological tests that you can. I'm sure it is possible. If it's possible in the UK, it's possible in India. That much I can understand.
Yes.
So you can have that character analysis, whatever you term you want to use, at every level, whether at the student level or at the teacher level. And I think in some ways in India, we have created this tier system even within doctors. Even within the doctor
Yes.
community, we have, oh, so that doctor, he is in the corporate hospital. That's where he works. So we have an image. The moment I say that doctor works in a big corporate hospital, a big corporate chain, he is the top doctor in that hospital, we have an image in our mind. It an image forms that this is the kind of doctor he is, this is the kind of car he drives, this is the kind of flat he lives in, kind of house he lives in, kind of city he lives in, this is his lifestyle. And then we think about a doctor who is a professor in a medical college in a certain part of India. So you just have to mention the location, the job, whether the hospital is government or private, and we all automatically have an image. And then we compare. We compare as doctors, patients compare from the point of view of patients, and then there is this sort of stratification of doctors. This kind of a doctor, that kind of a doctor. That doesn't exist in the UK. So, and for some, I don't want India's system to become like UK and then have the same problems that UK is having, only at a much bigger scale because of our much bigger population. But
Yeah.
at least we can normalize treating every doctor across specialities, across their workplaces, across their salaries. It should be same. And
Yeah.
as a person who has studied in a medical college and has seen so many people, other people studying in a medical college, everybody wants to be in a profession where they want to make enough to lead a good life. It should
Yes.
not be normalized that, oh, you are in the government college, why are you expecting so much salary? Do you agree that in many government jobs in India, we have seen it in
Yeah.
across the main motivation for going into a government job in India, in across all states, is the impact it will have on your private practice.
Yes. Definitely.
Yeah. And do you not
Yes.
see how paradoxical that is?
It is ill paid, but you are still getting it there for a job security as well as for
Yes.
a social position where people still have a bit of more trust
Yes.
in government doctors. Yeah.
100%. So,
Yeah.
the biggest mistake people make is to think that, oh, he's not a doctor, he'll not understand. Everybody understands. A patient who comes to you because you're in the government job, he knows that the opinion you are going to give is not going to be motivated by how much money you are going to make from that procedure. They know that. And they know that you have
Yeah.
been doing this from 9 to 5 for a long period. So when you go into private practice, your opinion is has carries more weight. than somebody who is working only in a corporate world. Many people will think like that. That because you have been in a government job, you're doing so much, you are seeing so many patients, your opinion somehow is better. They have that opinion. Even in the UK, there is independent practice. So UK also is not 100% government, so it's much more. The ratio is just the opposite, where in India, most people go to private healthcare. People who can't go to private healthcare go to government healthcare. In the UK, it's the opposite. So people who get frustrated with government healthcare, only then they go to private healthcare. That's much less. And even here, I have heard things that I've heard in India, that a patient comes to me and says, "I trust your opinion because you are independent. You are not motivated by the fact that if you sell this device, your company's bottom line will be improved. So you are not here to sell me anything. You are here to provide the right treatment." We can have that in India also. The problem with India is, and I have been saying this for a long time, that the incentives are completely wrong. You go into a corporate healthcare system, they give you incentives regarding the number of patients, the number of tests, all these things. Really bad. You don't want to do that. So you go into government healthcare. You want to treat patients properly. Then you're not paid enough. And then you think my colleague, who I think does not know as much medicine as me, he is doing less work than me, he is spending less hour in the hospital, he is having a much more balanced life, and he is making more money. So, and I don't want to do anything that he is doing that I don't agree with. So the only option I have is I need to do effectively two jobs. I'm doing my government job. I'm not taking non-practicing allowance. I'm following all the rules. When it is allowed for me to do private practice, I'm doing that also. Do you see how difficult this becomes?
Yes, definitely.
So, do you think that at least we can make an effort? I don't know. It's beyond our powers. Of course, we can never do it. But at least going forward, if we can make anything different on a system level, you should pay government employees, especially government doctors. You pay them like, because you are expecting a government doctor to be in every government hospital, and you expect a government hospital in every part of the country, right? So you don't think that, no, this guy is only going to be in Calcutta. He's only going to be in Mumbai, only going to be in Delhi. He has to be in you need healthcare everywhere, in every part of the country. What other thing do you need in every part of the country? You need the police everywhere. You need the bureaucrats everywhere. So if you can send, so I have never heard of this. Maybe it is possible, maybe because I don't have the knowledge, but I've never heard of it that people get into civil service and then they complain that, oh, I was sent to this village. They are more than happy. I got into civil service. This is it. Yeah, my life is fixed. I don't have to worry about anything. But we get into government. I have been in that position, getting into a government sanctioned post, and then you go into a place which has a population of 10,000, does not have any facilities. You mention that you need an MRI, they have to go into a different district to get the MRI done. And then you're not paid that well also. And the only people who stay there willingly are people who have been able to set up their private practice there. Yeah. So if those people even if you tell them that, okay, tomorrow you are going to Calcutta and you're going to be working in one of the best medical colleges in Calcutta, Kolkata, they will still not go because they have the private practice. So why not, instead of creating a situation where you're not paying you well and you are having to resort to setting up your private practice, which takes so much time and so much effort, why not make it same like civil servants? Do the same thing.
Yes.
Do the same thing. That's also a government job. If you are moving towards uniformity in exams, and we are moving towards uniformity in curriculum, we can move towards uniformity in the teaching service also. So have an all India teaching service for all the people who are teaching in government sector. At least start with the government sector, and then have the same pay, same perks,
Pay structure.
like bureaucrats.
Yeah.
I don't know why it's not possible. Your thoughts?
Yeah, it is possible. It is definitely possible, but the intent should be there. Positive intent is of utmost importance. And it's very sad to say that in India, doctors are basically the punching bags.
Yeah.
You will be punched by the patients, you will be punched by the government authorities also regarding things. And anywhere we have seen in India, whenever we are talking about any problem in the hospital, be it the cleanliness, be it the services, whatever it is, the first person who is held responsible is mostly the doctors.
Yeah.
A doctor's job is not to clean the hospital. They are not supposed to clean, and it's a responsibility of the authorities as well as the patients and relatives, the service takers who are taking the service. It's also a very important aspect from their part also. Cleanliness can be done when there is only uh, commitment from both sides. It's a difficult take in India, very difficult, no doubt in it, but not impossible, I must say. Let's see in the upcoming future, maybe we might be having a unified, what I would say, medical services uh, should be there. And I also feel there should be one in West Bengal, especially. There is a thing called the West Bengal Health Service and West Bengal Medical Education Service. We know that there are two
Yes.
spectrum. I
Yes.
think there should be a one single service called the West
Exactly.
Bengal Medical Service or whatever it may be, because
Exactly.
I have encountered people who are in the West Bengal Health Service who are not in the teaching cadre, I must say, but
Yeah.
they are brilliant teachers. They are willing to teach as well, but due to
Yes.
various reasons, one way or the other, they're not being able to teach students as well. But
Yes.
there should be the services should be unified
Yeah.
regarding, and people who are really interested voluntarily in teaching should be provided with attention that they so that they can teach.
So this is such an important point. You were in the West Bengal Health Service before you switched to West Bengal Medical
Yeah,
Education Service, and during your stay in the West Bengal Health Service, I kept telling you that you should be a teacher because that's what you did when you were a resident, and now you're not doing it officially in a formal role. It was, and I was doing it when I had no interest in teaching when I was a resident. I found that very strange and very unfair for students. So it's, at least that has been settled now. I want to tell you one thing. I'm sure now that you've become an assistant professor, you'll be on the other side of the exam table. You'll be the examiner. Um, I don't know if you're aware of this, but you know that do you know that there are fixed criteria to be examiner in India? NMC criteria.
I have heard, but I have not gone through what are the
Yeah.
exact criteria that I don't know.
So let's not discuss the individual criteria. It's too exhaustive.
Yeah,
But it's based on basically the number of years you have been an assistant professor, whether you have been a guide, or again you there are different criteria for being a UG examiner, different criteria for being a PG examiner. So there are lots
yeah,
of criteria you need to meet
yes,
before you become an examiner. Do you know what and I have been lucky enough to be a UG examiner towards the end of my tenure. In fact, I think the last working day in India till now. I don't know if I'll work in future again or not, but till now, my last working day in India, I was an examiner, a university examiner.
okay,
It is one of the most. I am extremely proud of that day because I had a certificate from from the college certifying that I have been a university examiner. It really made me very happy. But it took me 3 years. It took me 3 years as an assistant professor to be eligible to be examiner for MBBS exams.
an examiner.
Yeah, for the university MBBS exam. I
Yeah,
came to the UK. Within a few months, I received an email. First of all, there were some students. So here, I have not. I'm yet to encounter. You mentioned this thing about West Bengal Health Service and West Bengal Medical Education Service being unified. I am yet to encounter a doctor in the NHS seeing patients who does not have teaching responsibilities. There may be a teacher who does not have clinical responsibilities, but I have not encountered a single clinician who does not have teaching responsibilities. So everyone has teaching
okay,
responsibilities. So you know how it is. I'm in a new job, new country, new system, trying to understand what's going on. Takes time. I'm under a lot of pressure, trying to ensure I don't make any mistakes. And while I'm seeing patients, one student walks in and he says, "Do you mind if I sit in?" I said, "Yeah, why not?" And so he sits in. He observes me seeing patients. And he asks very intelligent questions. He's just doing ENT, so MBBS ENT. He's not a postgraduate trainee or something. He's just rotating through ENT, clinical rotation. He's sitting there. He asks me questions throughout the clinic. So we have 4 hour clinics here, 4 hours in the morning, 4 hours in the afternoon. At the end of the 4 hour, he says that, okay, I was here till now. Can I take your leave? I say, yeah, okay, fine. Then he tells me, I'll send you an email. Can you mark my attendance, please? So the system is slightly more sophisticated. It's not like a pen and paper. So you have to mark it as an email. It goes directly to the, I think, college. So a college in London will send their students to where I am now. So they go long distances for clinical postings. So this gentleman who was the student, he says that I'll send you an email. It will mark my attendance. I asked him, I have just joined. Do you think my permission is going to be enough for your attendance? I don't want your attendance to be jeopardized. So he says, no, no, it's fine as long as you are above a certain designation. So as long as you're not an intern. So for in Indian
Okay.
terms, here the term is foundation year doctor. As long as you're not a foundation year one doctor, which is an intern, you are eligible to sign my attendance. So I think, okay, it's just signing of attendance. What's the big deal? It's not a very big teaching responsibility. So I've signed it. Now that signature goes to the medical college here. And a few months later, I get an email from the medical college saying that you are invited to be the examiner for this year. And these are the dates. Are you available? Please confirm your availability. And I realized that I got that email because I had marked the attendance for that guy. So they now have a long list of emails of everyone who has provided some form of teaching. They expect that you don't mark the
Yes.
attendance without teaching at all. That is their expectation.
Yeah.
So now they have a list, email list of all the doctors in that area where their students have been to attend clinical postings. And now they have reached out to everyone. Now, I'm sure 100% of them will not say yes, some of them will say no. But I said yes. I said yes, and a few weeks later, they sent me a whole list of questions regarding do I have training, do I have previous experience of being an examiner. I said no to everything because obviously I don't have. Then they send me documents by email, and they are so secure that if I want to open them again, I probably will not be able to open. So it's highly secure, highly classified document. And then I go through that training, I confirm that yes, I have completed it, and then they tell me that they give me some dates, that which of these dates are suitable for you. I say this date is suitable for me, and they say okay, you can come on this date. This is final, and they ask me 3, 4 times. Long story short, the criteria for being a teacher is that you have marked attendance. That's all. And then you are trained. You go there. When I reached the place, I asked people, or they asked me mostly. I was not asking them, but they were asking me that what do you do? So I said I am an ENT doctor. Then I asked them what do you do? I am a general practitioner. So people of different specialities were all there. In India, what is the case? If you are taking an exam, if you are the examiner,
Subject wise.
if you are an examiner for ENT, then it is just being a specialist alone is not enough. So you are a specialist, you have to fulfill few more criteria to be an examiner. There, you don't even need to be a specialist in that subject. Yeah, I shouldn't say there, here. Here, you don't need to be a specialist in the subject for, I'm sure not for all exams. I'm sure there are exams where you do need to be a specialist. But point is, in India, we have this huge section of doctors who are never examiners. Like you will become an
Yeah.
examiner in the course of time. But your contemporary who is not in a medical college, who is in private practice, who may have the
Yeah.
knowledge, who should be having the knowledge, yeah,
Yeah.
because they have also passed the exams. So also can
Yes.
be good at evaluating at least an OSCE station, yeah.
Definitely.
And, but what happens there? You have this gatekeeping of okay, I can only so many people will be the examiners, and then the people are arguing about where I want to go to be an examiner. It puts so much pressure
Yes.
on a small pool of doctors who are now Their entire calendar is set up like in the month of January I'm going to the north of India, in September I'm going to west of India, in December I'm going to northeast. They are traveling the entire country. Instead, the part that you're going to, that part also has doctors. And I'm sure
Yes.
people enjoy traveling, and that is good. And the travel expenses are also paid by the university, which is also good. I'm not against that. But all of these expenses can be done away with if you make it easy by contacting people who are in the vicinity of the medical college.
Yes.
I mean, every medical college is in a place, I would like to believe, is in a place where there are doctors outside the medical college also. And
Yes.
if you can have enough number of doctors, you can have enough number of examiners. And then the argument will, but they don't know how to take exams. You can teach them. You can,
Yeah. Everyone can be
yeah,
taught.
you can teach them. Don't have to teach everything. You don't make it so difficult that, okay, you have to assess 50 students and 50 different questions, and don't make it impossible. Give them, like, I'll give you my example. I was given one station and I had to assess, and this is, mind you, this is in the UK. I am talking about doctors who have trained in the same system, passed the exams in the system, and now are practicing in the same country, Indian doctors. I am somebody who has trained in India, passed exams in India, and now I'm asked to be a UK examiner within the first few months of working in the UK. So they know that I will not know everything. So they've given me a small station on a small topic. Let me not leak the topic, but it is not related to ENT. So let's assume the topic
Okay.
was shock. Okay. Now I don't know. I'm not a postgraduate specialist in pathology. Okay. So I don't know the intricate details of shock, but I know something about shock, and they have sent me. Again, shock was not the topic, but they sent me enough literature on shock that these are the questions that uh, these are the things that the doctor should demonstrate. The student should demonstrate in the
Okay.
station. He should mention, so it was an OSCE station, so they have to describe to the patient. Again, patient is also somebody who's not a real patient, somebody who's playing the role of a patient. So the patient has some instructions. I, as the examiner, have some instructions, and obviously the examinee has instructions. That in this situation, the patient has presented, say, with shock. Then how do you deal with it? So I have a list saying that he should introduce himself, he should explain in simple words what shock means, and these are the precautions he should take, these are the things he should emphasize on. Is his demeanor, the way he's talking, does that show that he is experienced in this? So his demeanor should not be like a student who is just saying things, oh, but this was what was that? Not like that. He should be talking like a doctor with proper empathy
Yeah.
and finish in time. And my job is to keep quiet. Because in India, I have seen so many OSCE exams. Again, not correct, but in OSCE, you are supposed to not say anything. You're supposed to sit and observe. But in India, I have seen people. What did you say? Should you say like this? Can you think of something else? And then there will be some cross questioning happening as if it's a viva. So when we were students, we only had
Yeah.
vivas, where the examiner would be munching on some snacks and asking the world's most difficult questions.
Yeah. That is what I'm telling. That teachers should also be taught regarding how to take an exam.
And I don't want to say that starve examiners. That is not my message. Examiners should be fed. I was fed when I was an examiner in the UK, but there was a
Yeah.
designated time for it. When we reached, there's a time for coffee, there's a time for lunch, and there are comfort breaks. That was the term used. Comfort break. That means go to the loo, relieve yourself, don't have to control your bladder for a long time. In India, I remember senior doctors who literally felt boxed in. They were in this desk observing students for 3 hours, different people coming and going, maybe less than 3 hours, maybe 2 hours. But 2 hours is also tough if you have to do nothing but just mark. So naturally, they will
Yeah.
feel the urge to communicate, to keep themselves busy. If nothing else, if they feel the urge to go to the restroom, there is no time that you can allot to that. Final point I want to say before I let you go, it's been a long discussion. We will talk about only two things. Are you familiar with, have you ever had the experience while you were a student or while you were a teacher of a medical student breaking down and crying during an exam, an academic exam?
Uh, yeah, in undergraduate, one of my batchmates had a similar kind of thing experience, and in the postgraduate, when I was at the last hospital as I was posted, I saw a postgraduate resident during the final exam of MS ENT. Had She had this breakdown in a pretty bad way,
Yeah. So,
but
yeah.
examiners were kind enough, and she was counseled, and then she could successfully complete the exam.
So when you are preparing for conducting an exam, do you think that there is a provision in writing present how to deal with a student who cries or who breaks down during the exam? Do you think it's there?
Yeah, definitely, there should be. There should be. There
Yes.
should be. There should be. Yeah, everyone should be. Some examiners might react in a different way. So again, the same thing coming back to bring uniformity in every marking scheme. It should be there.
Yeah. Because it's understandable somebody will
It
cry.
can happen with anybody.
Yeah.
It can happen with
And
anybody.
and you can't stop the clock because you have to
Yeah.
run on time. You don't want people to their schedule to go haywire. Other students should not lose out because one person is crying. But that student also deserves attention. So there should be contingency plans which should be there in writing regarding this is what we are going to do. These people are there to take care of that situation. Anyway, final point to you. If you were the if you had all the power in the world, every power, whatever you wish would come true tomorrow, if not today. Then, what are some changes right from the medical entrance exam, the NEET UG level, to NEET SS and the exit exam for super specialization? Imagining that super specialization is the last thing that a doctor would study in India, although there's no limit to what we can study, but formal education would probably end at super specialization level. Starting from the entrance exam to the exit exam of super specialization, what changes do you want to see? And if you can implement them, you had all the power, what changes would you implement?
First, regarding the question pattern, everything I feel rather than just factual questions, it should be based on concepts that I feel is important. Because people think that medical science is something where you are only just mugging up things and just applying them. It's not like that. It takes a number of things. You have to take calls in difficult situations, and that is not purely based on what you are just learning and mugging up. So the exam pattern should be. It's okay that better. I always preferred a combination of multiple choice questions as well as something where you have to write it down. Uh, Descriptive aspect as well. That can be there. This is in the undergraduate level, and in the postgraduate entrance level, I feel that students should be allowed their own choice to what subject he or she is taking up, because many students are just because they are not being able to reach that particular cutoff for a specific subject and not getting the subject of their choices, and maybe compromising with the branch to what they're taking up. So I feel that MBBS is a very hectic course. People who are well trained in MBBS, it is expected that they will be very serious students as well. So in the postgraduate, rather than making it an exam oriented decision regarding which subject that person is eligible for, I feel they should be provided with choice. And like you said in your part of the UK where you are working currently, that interview system, it's based on a discussion regarding to assess whether he or she is really worthy of that specialty and taking up like that. I think it is a better option than just going for a 300 or 400 mark MCQ paper and just taking it up and just mugging and again, uh, like that. I would like these two changes definitely.
Mhm. Would you would you advocate any changes for the teachers in the medical education
Yes,
system?
teachers, see, every exam should be having an answer key, I feel, to bring uniformity, and every the question pattern uniformity is gradually coming up. Everyone is following a similar kind of a question, but the answer key, some there must be definite answer keys. Some examiner might prefer these kind of answers, some that differs, and it creates problems in the marking scheme as well. So examiners should strictly follow the answer key which they are provided. It should be point based, and it's just like they don't have any say of their own that okay, this is a good part and this is a just, if the student or the candidate has written these points in their answers, they should be given credit for that. That's way I think it should be framed regarding the marking scheme.
Right. Okay, I wanted to ask you one more question. I said this was final, but I wanted to ask one more question, and then you can ask me a question if you want. You have worked in perhaps the best government hospital in West Bengal, a place where I began my entire medical journey way back in 2008, Institute of Postgraduate Medical Education and Research. And you did phenomenal work there. You were there for how many years? Were you there?
I was there for 4 years.
4 years. 4 years of amazing work that you did there. And now you are working in a different part of the state. What
Yeah.
differences have you noticed based on the geographical difference, just because you're in a different part, just based on the difference in your physical location? What differences have you seen in the healthcare that you can provide as an ENT specialist?
See, considering the current ENT scenario, our subject is a very sophisticated subject, and we require a lot of sophisticated machinery to provide the best possible care to patients, from the point of microscopes to endoscopes and flexible endoscopes and whatever it is. So, because the place where I'm working is comparatively a much new medical college which is gradually coming up, it's developing, the resources are limited, and we do not have access to every kind of gadgets of ENT that we would love to have in our hands when we are working with patients. So yes, it's a ever growing process. We are setting our demands. We need these kind of instruments. We need these things for better patient care and better OT facilities, definitely. And I would like to draw your attention that recently, with a meeting with the government of West Bengal, we have been asked to start our planning for the cochlear implantation program at Cooch Behar Government Medical College and Hospital, and we are gradually making the lists of all the things that we need, the ergonomics that is to be needed for proper implementation of the program, and also regarding awareness generation among the common public here that such treatment facilities are available.
So is it something that is going to be there in Cooch Behar only, or is it related to the fact that you are qualified in cochlear implant surgery? Is it because of that?
No, as far as I recall, the new thing is that they're trying to implement this program in northern part of Bengal, uh, where this hospital is currently placed. Uh, so people will be coming up as a mentor as well if the program gets implemented. But it's a bit of a, we are making the list of what all we need and what all facilities before that, because cochlear implantation program is just not merely a surgery and finishing it up. It is a lot of pre-operative workup, intraoperative things, as well as in the post-operative rehabilitation, which should come in a complete package, because before we take up these children for surgery, so it is not just doing up with the surgery, take a child, go for the implantation. It's not like that. So it's a long-term process. I believe we are starting it off very soon. I am working on it. I have been provided with the full charge regarding what all we need for the successful initiation and implementation of the program. So let's see how long it takes.
Wow, that is such a amazing news. I just want to, just because I want to make it more broad, what do you think is the penetration of cochlear implant services across West Bengal? So I know it's there in Calcutta, in Kolkata.
Yeah, still there is definitely lack of awareness. I have come here for the last 3 to 4 months where I'm now currently attached, and I have encountered innumerable children, many children and their parents. Uh, Unfortunately, they have gone past the age where we need for a successful implantation. But the thing was the same, that they were not aware that such services do exist in this state. But definitely, it's better to start late than never, I
Yeah.
feel, because there will be problems which will be coming across, and let's see. Awareness generation is very important, and it should be through multiple social media as well as print media. It should
Yeah.
be generated that these services are gradually coming up in this part of the country.
So do you think, I don't know, I'm not aware of this, I'm just asking you, do you think outside Kolkata and now Cooch Behar, apart from these two places, anywhere else cochlear implant is done in West Bengal?
Mm, See, majority surgeries which I have come across are being done in Calcutta only. Uh, but I don't know. I'm not sure enough. Has it happened in any of the hospitals in Durgapur? I don't know.
No, no. Not while
Somewhere
I
I
was
can't
there.
recall. I was
Not
hearing
while I
that
was there,
someone in
no.
the private. Yeah, the gradually see the implantation surgeons are number wise. They are gradually increasing. Okay, earlier there was this thing that you do not do any manipulation of the inner ear, but with the results of cochlear implantation, and I am extremely satisfied with the implantees on whom I had implanted, and they are roughly around 1 year of follow up. They are coming up, not to my place, but I'm getting the video recordings of those patients, so of those children rather. So they are doing exceptionally well, and with the proper audio verbal therapy that they're undergoing now. So I personally, because I am a very I have so much interest in otology. Uh, I just want to create this awareness because what I find in this rural area is that parents are not having adequate knowledge, and for that, one I am trying to implement in my hospital. I'm trying to uh, create a rapport between liaison between the pediatrics department as well as the psychiatry department,
Yeah.
that as well as the gynecology, because they're the first one who will be encountering these children, is that to try to implement a universal neonatal screening
Yeah.
for hearing
Yes.
that should be
Yeah.
implemented, at least if not universal, at least screen the children who are at high risk for suffering from hearing loss.
But I think it should be universal because sometimes
Yes,
it can
definitely.
happen
Definitely.
even without any
Yeah,
other
ideally it
sign.
should be universal, but again, I'm talking about a resource limited setting where I am working currently. So at least it is better to have nothing than something. I mean, it's better to have
Yeah.
something other than
Yeah.
nothing,
No, I
rather.
completely agree.
So
We have to make a
yeah,
start at some place.
so you have to
So
start.
you
Yeah,
very rightly pointed out that if you have a neonatal screening, that is a very good method. I probably the best method in which you can ensure that you don't miss somebody who would benefit with cochlear implant, especially children.
yeah,
But then you require them in adults as well. Would you agree
yeah,
that in West Bengal, if you can demonstrate that you have the expertise, I'm purely talking about government medical colleges. So you have the expertise like you have of cochlear implant, and now you are able to set up. You're in talks. You'll be able to, hopefully very soon you'll be able to set up cochlear implant. The entire, as you mentioned, it's a thing that involves not just the surgery but also other specialists like audiologists. You need a good team to have a cochlear implant. Would you agree that in West Bengal, if you have the expertise and you are qualified enough and you reach out to the government, then it is possible to set up facilities irrespective of where you are geographically located, or is it based on Kolkata and big cities? Is it like that?
I feel it is possible to be if we have the human resource and if we have the proper fundings and infrastructure facilities. You don't need any multi-speciality kind of a thing or a hi-fi setting for an implant. The few important things are very important. You need to have trained men. You need to have a good team. You need to have people who will be following up these patients in the post-operative period. And last but not the least, you need to have a very sterile OT environment. That's of utmost importance for any implantation procedure. state government and the government authorities are kind enough to support us, this program can be taken up in different parts of the West Bengal as well. Why only in Calcutta? People, there are poor people who do not have money to take their children to a nearby town only. So how will they go to
Exactly.
Kolkata from this
Exactly.
distant part of the country?
Yeah, I couldn't have put it better. I hope
Yeah,
that this becomes a success, and there is a mentorship program also that you start in Cooch Behar, and I will definitely apply to learn cochlear implant surgery from you. I mean, it's not a West Bengal
sure.
problem, it's a problem in the UK as well. So in UK you have designated hubs, surgical hubs. So every surgery is not performed everywhere. I used to think it's more of a resource thing, but I don't think UK lacks resources. When you have
Yes.
resources also, then you need to plan, because you have to ensure there is no wastage. Everything should be accounted for. So in the UK, they have a system where there are surgical hubs, there are tertiary care centers. So it's accepted that if you are working in a certain hospital, certain surgeries are not going to happen there. And if you're working in a certain other hospital, then all surgeries are going to happen there. Maybe the ones which can be handled at a different tier of hospital, they can be handled there. But so septorhinoplasty or cochlear implant, these are all for a different tier of hospitals in the UK. Before we end, do you have any questions for me? Anything you are curious about the NHS or UK or anything? How many patients do I encounter in a day or a week?
Yeah.
Okay.
Patient
So
load, I mean.
that's such a nice question. So in India, I remember based on the hospital you work in, you would have you had a variation. So a big hospital, big government hospital in Kolkata, like IPJMR or RG both places we have both worked in, we would have number of patients which we lose count of. It's impossible to count. I could never count how many patients I was seeing over a 5 hour period from 9 a.m. to 2
Yeah.
p.m. You go to into a different hospital. I've worked in three different hospitals in West Bengal. You go into a government hospital in a smaller place, you have maybe 40, maybe 50 patients every day. You go into a private medical college, maybe even less. But the common factor across all colleges, all hospitals in at least the ones I have worked in, I'm sure there are places where it's different. But the ones I have worked in, I never knew before I went into the clinic and before I came out, I never knew the number I will encounter. It was never certain. I knew the times that I have to be there at 9 and I'll be allowed to leave at 2 or allowed to leave at 5. The time was fixed. The number of patients was never fixed. In the UK, both are fixed. So you have fixed time and you have fixed number of patients. This has changed across the different. I've worked in two different trusts now. In the first trust I worked in, I was allotted 10 patients for each clinic session, and each session would be of from 9 to 12:30, so 3.5 hours. Each patient was allotted a time of 15 minutes. So each
Okay.
consultation is 15 minutes. And this time is made available to, this slot is made available to the patients also. So you will not have a patient, technically you shouldn't have, it's possible, everything is possible. But technically you don't have a patient who has come in, say at 9 and is seen at 12. They are given a
Okay.
time that your slot is from 12 noon or at 10:30. So they will probably come in at 10:20. They're waiting for 10 minutes. At 10:30, you bring them in, you see them, everything's done, they leave. So in a given day, in my previous trust, I would have see maximum 20 patients every day. Maximum. Some of them may not turn up, so it can be less. But I have the list available to me in advance. So if required, so this is another thing that you can't go to a doctor directly in a specialist doctor. You can't go to a specialist
Okay.
doctor directly in the NHS. You have to go either through some form of referral. Either you are going through the GP, which is the most common thing. Again, GP here is not GP in India. In India, GP is somebody who has done MBBS and has decided to not do further specialization. That's a GP. Or somebody incorrectly, a medicine specialist is also sometimes incorrectly called GP. not correct. But in
Yeah.
UK, in order to be a GP, you have to go through training, GP training. That is, I think, a 3 year, or I'm not sure of the duration, but there is an entire training period. Maybe it's 3 years, maybe
Yes,
8 years.
yes.
I'm not sure. So they are also trained people. Their post graduation is in general practice. So they are GP.
Definitely.
They send referrals to a specialist when they feel it is required, or the accident and emergency, which is the emergency department equivalent here. So if a patient has gone to the emergency department, they feel ENT opinion is required, they send a referral, or some other specialist feels that this person requires ENT opinion, ENT review. These are the only three methods that a patient can reach. So already they have been through some proper evaluation by qualified specialists, either general practitioners or other specialists or A&E. And that evaluation is available to me
Okay.
on the computer. So everything is on the computer here. There is a bit of pen and paper, but in my previous trust there was no pen. I didn't have to use a pen. Now I have to use a pen, but in my previous trust it was 100% on the computer, or 100% digital on the computer. So all of this information, all the tests, everything was available there. So if I wanted to, I could read it on the previous night or on the morning of the clinic. I could go through the list, and if I have doubts, I could consult with somebody. I didn't have, I didn't need to, because you are so busy, you don't have time to do tomorrow's work today. It's just not possible. Even though it's technically possible, I'm sure people can do it. I never could do it. So the number was fixed. Another thing is, one of the biggest problems I had encountered, I'm sure you also will agree to this. In India, we used to get very upset when a patient would come to us having been to other doctors and would not bring their previous documents. And
Yeah.
you would ask them that what happened, have you been seen, even if it's surgery. So they'll come and tell you that, yeah, I had this ear surgery. And then you ask them which surgery, and then they don't know. For understandable reasons, how can they know the difference between a tympanoplasty, a mastectomy, or the types of tympanoplasty? You can't expect a patient to answer that. And you don't expect that in the NHS also, except everything is now on the system. So you can access
Legalized.
that. So yeah, that's the thing. It used to be 20 in my previous trust. In my current trust, it's 12 per clinic, so it can be 24. But another interesting thing about my current trust, here the hospitals are called trusts. So in my current trust, you have different clinics based on different diseases or different parts of ENT. So you
Okay.
have nose and throat clinic, where there are 12 patients. You have a general ENT clinic, which is like a mixed list. So there are also 12 patients. And here it is 20 minutes for each patient. So in my previous study it was 15 minutes, 10 patients. Here is 20 minutes, 12 patients. Except there is a vertigo clinic. In vertigo clinic, each patient is allotted either 30 minutes or 40 minutes.
30
Again,
minutes.
here there are two hospitals. In one hospital, they give me 30 minutes. I have done, I think, 4 vertigo clinics till now, if I'm not wrong, 4 or 5. And so in one hospital, it is 40 minutes for each patient, 6 patients only. 6 patients, 40 minutes. In the other hospital, it was also 6 patients, but 30 minutes for each patient. This is vertigo only. In India, again, for a vertigo patient, we had different questions. Here, you have the questions printed out. So I'm sure it is possible. You can implement it in your hospital also. So you know
Yes.
the questions you will
So it
ask
will be
every
better if you
vertigo
kindly
patient.
send me the question, and that will be beneficial for us also.
I can
We
probably
do
do
not
that.
have.
Yeah, probably do that.
Yeah.
So you can give the patient the questionnaire. They fill it up. Sometimes if they are not able to understand English, some people are not that good in English, especially if they are migrating from another country. One of them was from Bangladesh, so I communicated with him in Bengali, which was a very interesting experience, communicating in Bengali in England. Anyway, so yeah, so that a lot of time is saved. That you have the pro forma filled up, you have the questions answered,
Mm.
hearing test is done, and then you get to see them, and then you ask more questions. You do the vestibular examination, whatever is clinically possible. One of the things which I find restrictive for me is that all the vestibular tests that are possible, that is not done here in my current hospital. That's again restricted to a higher tier hospital. So that was something I had access to in India, but here I don't have access to that. But that's something I don't like. So it's not like everything here is great and everything in India is not. There are some good things about India. There are some good things about this. And my hope, having worked in both places, is that we can imbibe the good qualities of NHS
Yes,
and
definitely.
improve. And maybe even the NHS, if they are willing, they can learn many things from the Indian doctors who are working here and from across the world. One of the greatest things about working in NHS is like you're working in the United Nations because you meet people from almost every country. There's so many countries people I have met across two hospitals. It's just amazing. Any more questions, Dr. Moinak?
No,
No more questions?
fine.
You're exhausted by the first answer itself. Okay, it was a
Okay.
great conversation. It was
Yeah.
wide
After a
ranging.
long, long time.
Yeah, after a long time. I think this is the first conversation on video we are having with me in UK and you in India. So the previous time we talked, there was a role reversal. I was the assistant professor and you were in government health service. And so the next time we talked, you became the assistant professor and I went into health service, only national health service. Maybe the next time we talk, you will be in the UK and I
Both
will be
will.
in India.
No, not likely. Not likely.
Never say never. Okay. So thank you for finding time out of your extremely busy schedule and spending this
Yeah,
Friday
same to you as well.
afternoon for me and evening for you. Thank
Yeah.
you. I
Okay,
hope
thank
we
you.
will see you again on the channel again. Thank you.
Yeah, sure, definitely. Okay.
And good luck with your cochlear implant program. I am rooting for you.
It's a
I
long
hope it's
way
a
to
holy
go.
success.
It's a long way to go.
Yeah. But
Just starting.
I hope it materializes very soon.
Okay.
Thank you so much. Bye bye.
Thank you.
Bye
Bye
bye.
bye.